Hi, everyone. Thank you for joining us this evening for this webinar, New Lupus Nephritis Treatment Guidelines, What Patients Need to Know. My name is Jaron Crump, and I work here at the Lupus Foundation of America. And I'm going to just get us started with a few housekeeping items, and then we're going to jump right into the presentations from our speakers this evening, just for the sake of time. So we have a slideshow available. If we can go ahead and get that started. Thank you so much. So the first housekeeping items are related to technical assistance. If you experience any technical issues, you can use the chat feature to contact Safo Ajamai. She is listening, and she can hear everything that's going on, and we'll be able to address your issues right away. If you're disconnected, you can just rejoin using the link that's provided in the registration email. You can submit questions using the Q&A feature, and we'll address as many questions as possible during the dedicated Q&A portion. And please keep the comments in the chat and in the questions respectful and relevant to the discussion. After the webinar, we're going to send out a follow-up email with key takeaways, resources, and any relevant links. And if you have additional questions beyond that, you can contact Dr. Joy Bowie, who is the Vice President of Research here at the Lupus Foundation of America. Next slide, please. So there we have our speakers that are going to be here with us tonight, giving you more information about the new lupus nephritis treatment guidelines that came from the American College of Rheumatology. First up, with an overview of lupus nephritis, we have Dr. Brad Robin, who is a nephrologist specializing in autoimmune kidney disease, with a particular focus on how the immune system interacts with the kidney, leading to renal inflammation and injury. His work at The Ohio State University encompasses both patient care and research, advancing the way care is provided for individuals with complex immune-mediated kidney diseases. Dr. Rovin is a member of the ACR Treatment Guidelines Committee for Lupus Nephritis, as well as a member of the Lupus Foundation of America's Medical Scientific Advisory Council. Dr. Rovin, you can go ahead and take it away.
Okay, thank you so much for inviting me. It's a pleasure to be here. So I'm going to talk about lupus nephritis in general, an overview, and talk a lot about the kidneys. So if we can go to the next slide. These are my disclosures. I've been involved in a lot of the trials that have led to new medications being approved for lupus. I don't think any of this will conflict with what I'm about to tell you. Next slide, please. So lupus nephritis, simply defined, is an immune complex-mediated glomerulonephritis that occurs in patients with systemic lupus erythematosus. So let me break this down a little bit. Glomerulonephritis, I'll show you what that means in just a minute, but it's an inflammation of the glomeruli, which are the filtering units of the kidney, and I'll show you a cartoon shortly. Immune complex disease, as everyone on this webinar knows, in patients with lupus, you generate antibodies against antigens or proteins that are normally found in people. And when these complex, they generate immune complexes. And when the immune complexes deposit in the kidney, this is where things start to go awry. Next slide, please. Okay, so this is a nice schematic of the kidneys, and I'm going to try and illustrate how kidneys get injured with immune complex disease. So the large kidney on the left is a half section through the kidney, and the box is showing the cortex of the kidney, and inside the box is one of the filtering units of the kidney attached to the tubes that lead eventually to where urine comes out. And so this is called a nephron. And the little ball at the top is really a bunch of capillaries or small blood vessels through which filtration occurs. And if you see my crude immune complex, it's a Y with a blue dot. The Y represents an antibody and the blue dot represents an antigen. And in patients with lupus, these circulate in the bloodstream and then they can deposit in the kidney. So if you look at the far right, you see the glomerulus as a cartoon, of course, and you see the glomerular capillary networks. These are small blood vessels, and you see where I've drawn a bunch of immune complexes depositing in blood vessels. And where these deposit, we can start off the immune system activation and cause inflammation and eventually damage to the kidney. And so I want to first go over some of the general characteristics of lupus and lupus nephritis, and then show you some biopsy material from real patients who have had lupus nephritis. Next, please. So this is the incidence and prevalence of lupus, not lupus nephritis, but lupus in the United States. And what we see here is the first bullet point is new cases of lupus, written about rates per 100,000 individuals. So for lupus, it's about 6. And you can see on the right, RA is rheumatoid arthritis. Many more patients develop rheumatoid arthritis than lupus. And scleroderma is even more rare than lupus, about 2 patients per 100,000. Among men, as you all well know, the incidence of new cases is about 2 per 100,000, and it's higher in Black individuals than in white individuals, as shown on the right. And the real issue, of course, is that lupus is much more common in women, about 9 cases per 100,000 population. And you can see that between Black and white individuals, there's almost a doubling in the incidence when you look at Black individuals. Prevalence is cases of lupus that exist. These are the rates again per 100,000 patients. And you see, or 100,000 population, not patients. And you see a rate of about 73. And again, rheumatoid arthritis much more, and scleroderma much less than lupus. You see the rates among men and women, vastly more patients are women. And again, you see a predisposition to lupus in individuals of African ancestry. If you go down to the bottom, you look at the mortality rate. It seems that the mortality rate in patients with lupus is higher in men than women. But when you look at African Americans versus Caucasians, it's higher in African American patients. And we'll dissect this a little bit more in terms of nephritis. Next, please. Okay, so now this is the incidence and prevalence of lupus nephritis in the population. So I think it's really important to understand that kidney involvement is really common in patients with lupus. Up to 60% of adult patients with lupus can have kidney involvement, and up to 80% of children with lupus can have kidney involvement. This usually occurs fairly early in the course of ostensibly a lifelong disease, usually within the first 5 years. Many folks actually they're presenting signs and symptoms out of the kidney. The presentation is really quite variable. Patients can have subclinical involvement, or they can have a rapidly progressive glomerulonephritis. And what that translates to is very rapid loss of kidney function, usually within several months, weeks or months. And that's the most extreme form. Fortunately, we don't see that very often. This is associated, lupus nephritis in general is associated with significant morbidity and mortality. Next, please. So this is the risk of lupus nephritis, developing lupus nephritis in patients with lupus by race and ethnicity. And as you can see in the block graph, patients with African American ancestry have the highest rate of developing lupus nephritis after a diagnosis of lupus, followed very closely by folks of Hispanic ethnicity, and then a much lower percentage of patients who are white will develop lupus nephritis. And if you look at the population, I compiled these data from looking at literature describing over 2,000 patients. You can see the variability that we see in our populations of folks who will develop lupus nephritis after a diagnosis of lupus. And what you see here is that it's really a high incidence in everyone but Caucasian patients. Next, please. Now, end-stage kidney disease means that the kidneys are no longer functioning well enough to maintain a person without the need of either a kidney transplant dialysis, and I think probably most of you have heard of these things. But again, if you look at ancestry and the patients who develop end-stage kidney disease, uh, again, it's higher or highest in patients of African ancestry, patients of Hispanic ethnicity, and lowest in white patients. Next, please. This is a really important graph, and I think it really brings home sort of why we have to be very effective in our treatments of lupus nephritis. This is the life expectancy at a given age. The given age is along the bottom axis of the graph, and the life expectancy is years on the vertical axis. And you can see where the general population is. And then I've pointed out the yellow line with an arrow. Patients with lupus, not lupus nephritis, just lupus, have a lower life expectancy than the general population. If you add kidney involvement to lupus, then you see in the early years, when folks are younger, you have another decline in life expectancy, but it doesn't seem very big, but still, it's there. However, if you look at the very last line, the dotted purple line, lupus plus lupus nephritis that has progressed to cause chronic kidney disease, in other words, chronic damage to the kidney, has a very important negative impact on life expectancy. So by all means, when we diagnose kidney disease in patients with lupus, we want to do the very best we can to prevent the development of significant chronic kidney disease to give patients the longest lifespan possible. Next slide, please. Okay, so what is the kidney in health? The kidney is really a very smart filter. And the things that the kidney does when people are healthy is that it removes waste products from the blood that build up during daily living. So as we eat and drink and sleep and exercise, we metabolize energy, and we have byproducts that can be toxic. And so the body has to get rid of them. The two ways the body gets rid of things, of course, are through the gastrointestinal tract and bowel movements, and through the kidney, through the urine. And so this is one of the main functions of the kidney. The kidney is also remarkably good at maintaining the volume status of the body, so keeping us from becoming dehydrated or volume overloaded, too much fluid on board. The kidney helps to regulate blood pressure, as many of you know. And the kidney also is quite precise in taking back the things that filter through those glomeruli that the body needs. So certain electrolytes, proteins. We don't want a lot of stuff to get lost in the urine that's really important for keeping us healthy. So the kidney tubules, those long tubules I showed you in the cartoon at the beginning, are really good at deciding what needs to come out in the urine and what needs to be brought back into the body. And finally, the kidney can be thought of as an endocrine organ. It actually produces hormones. One of the hormones it produces is called erythropoietin. Erythropoietin helps us make red blood cells. And in patients with advanced chronic kidney disease, where it is not making erythropoietin very well anymore, patients become anemic. That's very characteristic of patients with advanced kidney disease. The kidney also takes vitamin D, which we all make when we're exposed to sunlight, for example, or you take supplements, of course. But vitamin D has to be activated through an enzymatic process, and that process, by and large, occurs in the kidney. Next slide, please. So the consequences of kidney dysfunction are really variable and protean. Waste products accumulate in the blood, and when that happens, we call that uremia, and it can cause fatigue, confusion, nausea, weight loss, weakness, chest pain, and severe itching. Fluid can accumulate, causing swelling of the legs. You can also swell internally, and you can get heart failure and lung congestion. And this makes blood pressure, when you have too much volume on board, this makes blood pressure very difficult to control. Electrolytes are very precisely balanced by the kidney, and electrolytes are sodium, potassium, and bicarbonate. They can go out of balance and lead, for example, to acid accumulation. The kidney buffers all the acids that we accumulate over the course of the day. It can lead to confusion if your sodium levels go too high or too low. And if your potassium levels go too high, you can have dangerous heart rhythms. And if the potassium levels go too low, you can have muscle weakness. So we need to keep these things very precisely aligned so the body works properly. Bone disease develops. Patients, as I just discussed earlier, can develop anemia or low blood counts. Patients with kidney disease have an increased risk for cardiovascular morbidity and mortality. You've all heard about, well, oh, cholesterol is a risk factor for heart disease, blood pressure is a risk factor for heart disease, chronic kidney disease is also a risk factor. And it depresses the immune system, and you have an increased risk of infection. Okay, next slide, please. Okay, so the goal of therapy is to preserve kidney function and to prevent the future need of kidney replacement therapy. We need early diagnosis, rapid institution of therapy, early control of disease activity, and we need to prevent disease flares. So I'm going to quickly show you some data to this effect. Next, please. So in conventional practice, we suggest that patients with lupus who develop proteinuria more than 0.5 gram a day should receive a kidney biopsy. Is this really good enough? And I'm showing you some data on patients with extremely low-level proteinuria, and they have histologic classes of lupus nephritis that are quite worrisome. So I would tell you that we are now trying to think through whether or not we need to look more carefully at patients who develop even lower levels of proteinuria so we can catch the disease early. Next slide, please. The kidney biopsy is an essential tool right now. The kidney biopsy will be done in patients who have blood and protein in their urine. The most likely diagnosis in the lupus patients will be lupus nephritis. But I will tell you that often the biopsy is not done to make the diagnosis, but to confirm what we think, exclude other disease processes that might occur with lupus nephritis. For example, 25% of our patients will have small blood clots in the urine as well. The most important part of the biopsy, in my opinion, as a nephrologist or kidney physician, is to understand the level of inflammation in that person's biopsy, the level of disease activity in that individual's biopsy, and the level of chronic damage to the kidneys. And that will allow me to choose how best to treat that person. We want to try and put, you're going to hear about the guidelines from my colleagues very shortly. This applies in general, and then we want you to work with your physician to get this right for you as an individual. Okay, next slide, please. So here I'm showing you some pictures of the glomeruli, which are the filtering units that I showed you the cartoon in the beginning. And what I show you on the very left is a normal glomerulus, and this is from a healthy kidney donor for a transplant kidney. And you see all the little things in the middle, these little things with holes in the middle. Those are blood vessels. They're open blood vessels. Everything looks good. This is perfectly healthy. If you look at the class 2, which to me is sort of an early phase of lupus nephritis that can transition to more severe disease, you can see that there's a little bit more busyness in the kidney on the purple picture. And then if you look on the gray picture, that's called an electron microscopic slide of the biopsy. And you can see some really dark arrows. I can't use my pointer, but some really dark areas. Those really dark areas are called dense deposits, and those are the immune complexes that I showed you that deposit in the kidney that cause all the trouble. If you move over to the right, you see what class 3 and 4 lupus nephritis look like. And now, if you're looking at the sort of pink-purple picture, yes, where the arrow just was, you don't see any openings in those glomerular capillaries because they are stuffed full of inflammatory cells. And that's a real problem because can you imagine getting blood through there to filter? The answer would be no, you shouldn't imagine that. It's very difficult. And then if you look at the electron microscopy on the right, do you see that big, huge black thing that's off to the upper right? That is called a hyaline deposit. It is a huge accumulation of immune complexes in the kidney, and you can see how that would damage the kidney structure. And then if you drop down to the bottom row, you can look at class 5. Class 5, it doesn't look as busy as the other ones. And class 5 is called a non-proliferative form of lupus nephritis. However, and you have to sort of be experienced to see this, if you look at the glomerular blood vessel walls, they look very prominent in that picture. And that's because they get really thick. And they get really thick because the immune complexes are forming right inside the glomerular basement membrane. And that's what all those black dots are in the electron micrograph that's to the right. Right in the middle, of course, lupus does a lot of unusual things, and you can have combinations of proliferative disease like class 4 plus class 5. And you can see here the dark deposits are on both sides of the glomerular capillary wall. You'll be tested on this later. I'm just kidding. But the point is that you see a lot of areas where the immune complexes can damage the kidney. Class 6, you don't want that. Class 6 is a kidney in which you probably don't even know that this is from a kidney because nothing looks good. Everything is scarred over. And this is unfortunately what a kidney looks like when we get ready to get a patient ready for dialysis or transplant. Next, please. So when we have an active lesion, that's where we want to sort of focus our therapy. So we want to diagnose that early. Whenever you have active lesions, you eventually do get some scarring of the kidney, but we want to stop it there. And we want to go and take the bottom pathway, which is just leaving the kidney with mild chronic damage. We want to X out the top pathway where we have extensive chronic damage. We don't know how to treat chronic damage right now. We can't reverse it. It's like a scar. Well, it is a scar and a scar inside the kidney. And so we can't fix that yet. Now, we are working on anti-fibrotic drugs to try and see if we can prevent scarring or even reverse scarring, but that's not where we are yet therapeutically. Next, please. So this is one of our studies, and I know there's a lot of lines here and everything, and one's green and one's orange. Don't worry about that. It's showing the same thing. What I'm showing you here is that at time number 0 is when a patient was diagnosed with lupus nephritis. They then received the best therapy available at the time. This is a cohort of patients of about 100 patients, and these patients did spectacularly well. They did as well as anyone could hope a patient population could do. And yet, getting the best therapy instituted very quickly after the diagnostic biopsy, you see that there's a rise in the chronicity index in both of those graphs. And what that simply means is that even as we're treating as good as we possibly can, you develop scars very early in the process. So you can see the earlier we get a person under treatment, the less of this happens, and then we preserve more kidney mass. Next slide, please. So a couple of, well, sort of busy sciencey slides, but the bottom line is that early response leads to less chronic damage. On the left in the table, early remission was defined as 7 months or less after a patient got diagnosed with treatment, and late is beyond 7 months. And I'll draw your attention to the two bolded rows. One is the GFR, and you can see GFR, it means glomerular filtration rate. That's how we define kidney function. Normal is over 100. And you can see that the patients who remitted early actually preserved their GFR, whereas the late remitting patients had a decline in GFR. Not a decline sufficient enough to cause trouble, but yet a decline. And I think this is important, and it'll come up in my last slide. And then you can see the percentage of patients developing chronic kidney disease. So we define chronic kidney disease as a GFR less than 60, and you see that the late remitters almost twice as often develop chronic kidney disease than the early remitters. This is shown again in terms on the right in the two graphs in terms of kidney survival or stage 3 kidney disease. Kidney disease is graded by stages. Stage 3 and 4 are very severe chronic kidney disease. Stage 5 is when, unfortunately, one needs dialysis. And you can see that in the red lines, if you achieve CRR, complete renal response, you preserve your kidney much better than if you do not achieve complete renal response. If you achieve complete renal response in the bottom graph, you avoid stage 3 or greater chronic kidney disease, where you get a lot of the complications I was talking about. If you don't achieve that, you have a tendency to develop severe chronic kidney disease. Next, please. So every lupus nephritis flare likely damages the kidneys. This is data from one of my former fellows, and the very top dotted line is the first kidney flare. And so that shows over time patients at risk for developing end-stage kidney disease. And the middle solid line and then the dashed line below it is that more and more patients are likely to do that every time they have a flare. And the reason for that, I think, is because every time you have a flare, no matter how well we treat it, you build up some more chronic damage. And if you have enough chronic damage in the kidney, then no matter what you do with lupus nephritis, you can stop it completely. The kidney, because of the way it works, continues to progress towards end-stage kidney disease. So we never want to reach that point if possible. Next, please. So this is my last slide, and I think I'm on time. But to me, the best way to approach kidney disease and lupus is to always remember the motto that I teach my fellows is time is nephrons. We want to hop on the diagnosis as quickly as possible. We want to get therapy started as quickly as possible, and we want to prevent recurrent disease by preventing flares of lupus nephritis. And now my colleagues are going to tell you how we do this in the new era of lots of medications. So thank you for your time.
Thank you so much, Dr. Rubin. That was a really insightful presentation. Thank you for laying the foundation for this webinar. Up next, we have Dr. Linda Haraki. Her presentation is Treatment Options for Lupus Nephritis, Mechanism and Side Effects. Dr. Haraki is a clinician scientist in the Division of Rheumatology and a scientist in the Genetics Genome Biology program at Sick Kids Research Institute. By identifying genetic and environmental risk factors, her research aims to enhance risk stratification, prevention, early intervention, and targeted treatments for complex rheumatic diseases. Dr. Haraki is a member of the ACR Treatment Guidelines Committee for Lupus Nephritis and is also a 2023 recipient of the Lupus Foundation of America's Pediatric Lupus Research Grant. Dr. Haraki, please take it away.
Thank you for that kind introduction. And thank you to LFA for inviting me to be part of this. And thank you all for taking time out of your evening to be with us tonight. Dr. Rovin gave me a great setup to move into discussing medications. Next slide, please. So overall, the approach that we're going to discuss is to control disease activity, as Dr. Rovin said, prevent permanent organ damage and complications, and that can include ensuring complete vaccination, maintaining bone health, and overall minimizing glucocorticoid exposure, and I'll talk a little bit more about that, as well as screening and treating comorbidities. Next slide. So there are a number of medications that are used to treat lupus nephritis and that are included in the recent ACR Lupus Nephritis Treatment Guidelines. And I've organized them into broad categories here. Antimalarials, specifically, I'll talk about hydroxychloroquine, glucocorticoids, conventional immunosuppressive medications, which generally in this talk, I'm going to talk about MMF, cyclophosphamide, and azathioprine, There are calcineurin inhibitors. And then lastly, biologic immunosuppressive medications. And I'll focus on two that are part of these recommendations, rituximab and belimumab. Next slide, please. So just a comment, though, about all of those medications. As Dr. Rovin pointed out, we're talking about lupus, which is a disease of inflammation. And so all of these medications are acting to decrease inflammation in the body. But of course, inflammation is one of the ways that our body fights infections. So as you'll see when we go through it, we'll see why increased infection risk can be a side effect for some of these medications. So sorry, going to the history of antimalarials, I thought this was a little interesting bit of trivia. It was in the 9th century that lupus was first described in the Bishop of Liège, currently Belgium. And this is a painting of the bishop being treated for his symptoms. And then in 1630, the Countess of Chinchon was successfully treated with powdered cinchona bark, which is the origins for quinine. In 1894, there was a description of a lupus rash that had been effectively treated with quinine. And in World War II, quinacrine was used as malaria prophylaxis, but it was observed that it also helped soldiers with their rheumatic symptoms. So when I introduce antimalarials, specifically hydroxychloroquine, to patients, I'll often mention this is one of the oldest medications that we've used to treat rheumatic diseases. Next slide. So how does hydroxychloroquine work? So this is a very busy cartoon showing the many ways that hydroxychloroquine can work to suppress inflammation. It can suppress autoantigens, so that self-auto stimulus to inflammatory cells. It blocks toll-like receptor signaling, which can then inhibit interferon alpha. Interferon is one of those chief inflammatory proteins that has been observed to be a major driver in lupus inflammation. It can inhibit endosomal NOx in neutrophils, so that ultimately leads to decreased release of this interferon cytokine again. And lastly, it can prevent a lot of inflammatory cells, T helper cells, B cells in their activation and differentiation, which again will decrease inflammation. Next slide. Next slide, please. So there are many effects that lupus nephritis has been observed, that hydroxychloroquine has been observed to have to improve treatment of lupus nephritis. When people are taking hydroxychloroquine, it can be linked with reduced overall corticosteroid exposure. It can reduce disease activity. It will extend the time to end-stage kidney disease or kidney failure that Dr. Rovin was referring to. Being on hydroxychloroquine can reduce mortality. And when hydroxychloroquine is combined with adjunctive immunomodulatory treatments, some more that I'll talk about soon, it can improve the duration of renal remission or disease quiescence. Of course, for all of these medications, there are side effects. One of the most common is gastrointestinal symptoms. And one of the ways that I suggest to my patients that we can modify that or mitigate it is taking it at night. And hopefully people are not finding it too distressing and they might sleep through some of those minor GI upsets. There is an increased risk of retinopathy or effects to the back of the eye and the retina. And that's why the American Ophthalmologic Association or Ophthalmology Association will recommend screening after being on hydroxychloroquine for 5 years. But to put that in context, what's been observed and when people taking it for 10 years or more, that the prevalence is only less than 2%. So it is one of those things that does require close monitoring, and it's usually a function of how long you've been on hydroxychloroquine and how much. More recently, there's a recognition that there can be effects on the heart, rarely cardiomyopathy, so that's a problem with the muscle of the heart. And hydroxychloroquine can interact with other medications like certain antibiotics or antidepressants that may change the rhythm of the heart. So being aware of those potential interactions are really important to ensure that it won't interfere with the drug. It's also been reported that there can be skin hyperpigmentation or darkening in the skin. And so again, that's something for people to be aware of. And just Because we're talking about lupus nephritis and because we're very concerned about kidney function, it is important to note that the dose should be adjusted if there's evidence of any problems with kidney function. Next slide. So next I was going to talk about glucocorticoids, and this was a really nice timeline taken from a recent review published earlier this year. And again, I really like how they're depicting the evolution of the use of glucocorticoids, specifically for the treatment of lupus nephritis. So cortisone was first used to treat rheumatoid arthritis in 1949. And then in 1955, prednisone and methylprednisolone became available to use for lupus. It was in the 1960s that high-dose prednisone became the standard therapy in lupus nephritis, and the first randomized controlled trial in lupus nephritis was 1972, where they introduced azathioprine as a steroid-sparing agent. So what this timeline depicts is how this treatment has evolved, and I think it's a really nice setup for what Dr. Askanase is going to talk about with the guidelines of how we've arrived at today's present day recommendations that are primarily focused on IV methylprednisolone and oral prednisone. Next slide. So again, glucocorticoids is a potent drug. They work quickly, more quickly than some of the other drugs that we've talked about. In contrast, hydroxychloroquine has a very long half-life. It can take months to reach a steady state or a state where it's sort of at an effective level in the blood, whereas glucocorticoids can work very, very quickly. They easily pass into cells and they bind to these glucocorticoid receptors. And their two main effects can be segmented into genomic effects and non-genomic effects. The genomic effects means that the drug can change gene expression of inflammatory proteins. And the non-genomic effects are through bindings of membrane receptors that can then impact inflammatory signaling. Next slide. So this was from that same review where they're outlining a lot of the side effects that can come with chronic long-term exposure to glucocorticoids. So on the left, you see osteoporosis. We know that when someone is on glucocorticoids for an extended period of time, it can decrease the strength and the density of bones. So routine bone mineral density testing is important, ensuring that there's adequate calcium and vitamin D supplementation to maintain bone health. And then in some instances, it may be necessary to treat with bisphosphonates that can strengthen bone. Hyperglycemia is also a potential side effect that can be mitigated with lifestyle modifications. Cardiovascular disease, another side effect. Of course, infection risk, which can be mitigated with ensuring up-to-date vaccinations, and in some instances, using prophylactic treatments like antibiotics. And then adrenal insufficiency, which can happen when you have prolonged exposure to glucocorticoids and your body is not making the same amount of cortisol, sort of our own natural version of these glucocorticoids or steroids. I've also added some other side effects, just next. And these are things that people can experience in the shorter term, being exposed to steroids, like having physical changes, maybe noticing a bit of a puffier face, experiencing weight gain, disturbed sleep, mood, acne, striae, growth delay in the children and teens I care for, and delayed puberty. And I would say these complications on the right are some of the most distressing to the patients that we care for sure. Next slide. So I'm moving on to MMF and MPA, so mycophenolate mofetil and mycophenolic acid. MPA was first described in 1913 as an antibiotic and anti-inflammatory. And MMF is a prodrug to MPA. So in the cartoon, you can see that plasma esterases convert MMF to MPA. And in 1995, the FDA approved MMF to prevent transplant rejection. So how it works is it inhibits guanine nucleotide synthesis via de novo purine synthesis. And what that ultimately means is you have less inflammatory cells proliferating or being generated, and in turn, less antibody production. Next slide. So the side effects are most commonly gastrointestinal with constipation and diarrhea. There's also cytopenias or low cell counts, so low hemoglobin, low white count, and low platelets. There can be an increased risk of infection and possible malignancy, although this has not been adequately replicated. So how can we manage some of these side effects? So one way is to gradually increase the dose, so titrating it up over days or weeks, and frequent blood work monitoring to ensure that the counts are maintaining a healthy level. Next slide. Next is cyclophosphamide, and this was first introduced for use in lupus nephritis by an NIH study in 1986, where they compared prednisone versus prednisone plus oral cyclophosphamide and found that there were reduced frequencies of flare in patients who were treated with cyclophosphamide, sorry for the typo, compared to prednisone alone. And how does it work? So in this cartoon, you can see cyclophosphamide is there with MMF and azathioprine that I'll talk about again as one of these agents that can again reduce cell proliferation or reproduction of these immune cells. And that's how it can have this immunosuppressive effect. Next slide. So some of the side effects again are low cell counts, infections, hemorrhagic cystitis, which can be bleeding in the bladder, premature ovarian insufficiency, and malignancy. So how do we mitigate this? Oral doses are not as commonly used nowadays as they used to be in the past. And what that means is people overall are getting lower cumulative or overall exposures to cyclophosphamide. And we tend to track how much cyclophosphamide a person has been exposed to. There's also close blood work and urine monitoring to look out for these side effects. Next slide. Azathioprine was first developed by Nobel laureates in 1957, Hitchings and Elion, and it again is a drug that was created to inhibit cell growth. That's a theme, as we're seeing, right? A lot of these drugs are inhibiting cell growth and cell replication. Azathioprine is a prodrug to 6-mercaptopurine, which again blocks purine synthesis and then decreases lymphocytes and immunoglobulin synthesis, and is relevant in this conversation because it's safe during pregnancy and will often be a drug that's recommended in people to manage lupus while they're pregnant. Next slide. It also has a range of side effects: gastrointestinal, low white count, infection, possible risk of malignancy. And the other one to be aware of is it can have severe hematologic toxicity, so severe drops in cell counts for patients who carry certain genetic changes in TPMT or Nudix 15. So how can this be mitigated? Gradually titrating up the dose, close blood work monitoring, and testing for these genetic changes in advance to starting the medication are all ways that this can be managed. Next slide. So now I'm going to shift to calcineurin inhibitors. In 1986, it was the first report of tacrolimus that was used to rescue liver allografts or transplants that were being rejected. And in 2021, voclosporin was FDA approved for lupus nephritis. So these two cartoons on the left, the far left shows tacrolimus, and the middle shows voclosporin, and how they're suppressing the NFAT pathway, inhibiting IL-2 and lymphocyte activation. Next slide. So you can see the side effects are comparable, but at different prevalences between tacrolimus and voclosporin, and a range. Nephrotoxicities, one of the potential side effects, so that's some damage to the kidney itself. There can be side effects of high blood pressure as well as infection. So again, they need to be used and close with caution when people have reduced kidney function, with close blood work monitoring, and in some instances, if someone has been on tacrolimus for an extended period of time, it may be necessary to perform a kidney biopsy to see if there's evidence of damage as a consequence of being on tacrolimus for an extended period of time. Next slide. Okay, so these are the biologics or B cell targeted therapies for rituximab and belimumab. And this is that same figure, and you'll see them on the right-hand side with the B cells. B cells are the immune cells in our bodies that make immunoglobulins. And you can see in 1997, rituximab was FDA approved to treat lymphoma. It's a CD20 monoclonal antibody that basically destroys B cells. So that's the way it decreases antibody production. And then in 2011, belimumab was FDA approved to treat lupus, and it's a B cell activating factor or BAFF monoclonal antibody. So it's blocking the interaction with soluble human bliss or B lymphocyte receptors. So they're all close to the B cell, but they're acting in different branches or different arms of B cell immune activity. Next slide. So here are some of the side effects. Rituximab has been linked with infusion reactions, but again, a huge range of how common that is. It can be linked with hypogammaglobulinemia. So again, as I was describing, it's reducing immunoglobulin production, which is how it's working. So not only is it decreasing auto antibodies, but other antibodies. And in some instances, it can be hard for people to recover those protective immunoglobulins that protect them from infection. So that is a potential complication with rituximab. It can be linked with low neutrophils or neutrophil counts, neutropenia, infection, and serious infection. Belimumab as well, there have been reports of infusion reactions, infections, and serious infections. And the other side effect that to be aware of is a risk for depression and suicidal ideation. So ways to mitigate all of these side effects is with close blood work monitoring, immunoglobulin monitoring, and with belimumab, mood screening. Next slide. So in summary, I hope I've outlined that these medications are all operating in different ways to help control disease, and that our management has evolved a great deal over time. And what we now have is an opportunity to use a multi-pronged therapeutic approach targeting different inflammatory pathways that I think have offered many more options to patients. And certainly we have more medications than we've ever had before. So I think it's a really exciting time where we have a lot of therapeutic options, and that there are certainly side effects, but hopefully I've offered some strategies that can mitigate or manage these side effects and complications. And so I believe we're taking questions at the end. Hopefully I've stayed on time, and I'll pass it over to Dr. Askanase.
Yeah. Thank you so much, Dr. Haraki, for sharing all that information about the treatments. I see we're getting some responses from folks in the chat. Just a quick reminder, if you have questions, you can put them into the chat or in the Q&A feature. We're going to have some time after our next guest where we're going to be answering some questions. Our panelists are going to stick around for that. And also just want to take a minute to thank Dr. Rovin, Dr. Askanase, Dr. Bowie, Dr. Haraki, everyone. I see you answering some of the questions that people are sending in already, which is great. So thank you so much. And our next speaker is Dr. Anka Askanase. The subject is applying the ACR 2024 guidelines to the treatment and management of lupus nephritis. Dr. Askanase is the founder and clinical director of Columbia University's Lupus Center and the director of rheumatology clinical trials. Her research focuses on improving care for lupus and autoimmune patients by redefining therapeutic options and disease outcome measures. Dr. Askanase is a member of the ACR Treatment Guidelines Committee for lupus nephritis and for SLE, and is also a member of the Lupus Foundation of America's Medical Scientific Advisory Council. Dr. Askanase, it is a pleasure to have you here. Thank you so much for joining us.
Thank you for this very kind introduction, and thank you all for spending time with us to talk about lupus nephritis and think about the guidelines and how they may impact you or your family and friends. These are my disclosures. Next slides. So this is the guidelines team. I put this slide up to show you that it was a large group effort. A lot of people were part of thinking about the guidelines, making decisions and voting about the guidelines, reviewing the literature. And of course, we had 14 patients that worked with us throughout the process to ensure that your voices are heard and we have taken into account your preferences and your thoughts about the treatment of lupus nephritis. Next slide. So I put this slide to show you that it was a lot of work. The literature review team reviewed over 10,000 publications to put together the most relevant data so that as we think about the guidelines, we have all this information at our fingertips. Next slide. The methodology that was used is a methodology that the ACR has been working with through developing guidelines for various diseases. It's called the GRADE methodology, and it basically thinks about every question that we might want to have about how to treat a disease or how to address a disease. In this, it's called PICOs. So population, figuring out who the question is about. Here, it's about people with lupus nephritis. Intervention, what is the drug that, or what is the device or procedure that we're thinking about. Comparator, so we're comparing intervention versus no intervention, or intervention A versus intervention B. And outcome meaning, quality of life, no kidney disease, making lupus better. So this is sort of the frame of thinking about the guidelines. Next slide. At the end of all this process, we were supposed to come up with strong recommendations. These are recommendations that most people in this situation would want to do. So maybe a small proportion would not, but the majority of people would take this course of action. A conditional recommendation is the majority of people would recommend this, but many would not. So it's a little bit of a milder recommendation. Next slide. So we started with some guiding principles. So the guiding principle is preserving kidney function and minimizing morbidity and mortality from chronic kidney disease and treatment. So Dr. Rovin, my friend and colleague, already told you that time is nephron. So it is very important to preserve the nephrons. The nephrons make the kidneys function. So we'll need to preserve that. The second guiding principle is collaborative care. We're here together with our nephrology colleagues. In your care, this needs to be a team effort where the nephrologist and the rheumatologist work together. Use shared decision making, meaning we include you, the patients, in making the decisions about your healthcare. Aim to reduce healthcare disparities and consider special populations like children and older adults when we're thinking about how to make these decisions. So we came up with 28 recommendations, 7 were strong, 21 conditionals, and then we also came up with good practice statements, meaning things that are obvious, but every doctor should think about them. So our colleague that is very versed in this methodology and whom I have to thank, our colleague Lisa Imundo, that put together some of these slides, says, well, falling out of an airplane without a parachute, you don't need to test that. So think about these good practice statements as in you don't need to test them because they're obvious. Next slide. So what are some of these recommendations? We recommend that we check proteinuria every 6 to 12 months or at a time of flare in all patients with lupus that don't have lupus nephritis. If we suspect lupus nephritis, we need to perform a kidney biopsy promptly. If indeed we diagnose or suspect lupus nephritis, we need to start prompt treatment with steroids. The kidney biopsy is indicated for a proteinuria level greater than 0.5 grams per gram. Hydroxychloroquine is recommended for all patients. Renin, angiotensin, aldosterone inhibitors are also recommended for patients with elevated proteinuria. And we need to adjust medication dosages for patients that have decreased kidney function. Next slide. So, in terms of the first step to treating lupus nephritis, steroids continue to be our first step. Now, the recommendation may be a little different from what we were doing in the past. We start with intravenous steroids. We call that pulse steroids, and we administer between 1 and 3 doses of intravenous steroids, and we follow that with oral steroids. Different from the past, the dose is relatively low, less than 0.5 milligrams per kilogram. So for an average person, it is for an average person of, say, 70 kilograms, that's about 170 pounds, it's about 35 milligrams. And then taper the dose over the next 6 months to less than or equal to 5 milligrams, aiming to completely get rid of steroids. Patients and physicians alike strongly emphasize that we need to minimize steroid use. But the tapering, how we get down from the 35, 40 milligrams to 5 and 0, needs to be based on what's happening and how the patients are feeling. Next slide. So this is sort of our masterpiece, the work that we've been putting together for over a year, thinking about how best to recommend treatment for lupus nephritis. So the big deal is that we're saying time is nephron. You need to act quickly. You need to hit lupus nephritis hard in the beginning. So we are recommending something that we decided to call triple therapy because there are 3 classes of medications we're using. Steroids, mycophenolic acid analogs, so some of you might know that as Cellcept, which is mycophenolate mofetil, or Myfortic, which is mycophenolic acid, in association with belimumab or a calcineurin inhibitor. So 3 drugs, steroids, mycophenolic acid analog, and then one of the newer therapies, either belimumab or calcineurin inhibitor. And we're going to get into some examples to better understand how to use this. And we divided the treatment of lupus nephritis in people with proliferative, class 3 or 4 lupus nephritis, and class 5, the membranous. Remember, Dr. Rovin showed you those extraordinary biopsy examples, those slides that kind of highlight the differences, proliferation versus more thickening of the glomerular structures. So this is the big summary. Of course, everybody should be on hydroxychloroquine and these blood pressure medications that help decrease the blood flow to the kidney and minimize the risk because of the elevated blood pressure or the big blood flow to the kidneys. Of course, there are alternatives, and some of those alternatives include cyclophosphamide. So we're considering options depending on individual situations. But the big thing is hit hard with all the drugs, put them all together, make the biggest impact. And I'm very grateful to Linda for kind of introducing what those drugs mean and how they work so that it makes sense that we're trying to hit the kidneys in many ways, the inflammation, not the kidneys. We're trying to reduce that inflammation quickly and very effectively. And of course, as things get better, figuring out how to start getting rid of some of these medications. Next slide. So we spoke a little bit about the non-immunologic therapies that need to help us improve kidney health and prevent comorbidities. We also recommend quantifying proteinuria throughout the treatment. So we don't say goodbye, here are the medications, I'll see you next year. It's throughout this process, we're evaluating constantly to see, have we achieved the goal of complete renal response? And then what, and if we haven't, make a change. Next slide. So I thought I would like to share the story of a lupus patient. This is a 29-year-old woman that had had lupus for 3 years. She has had arthritis and hair loss. She had positive ANA and double-stranded DNA that comes to a routine clinic visit. She is taking hydroxychloroquine and a low-dose steroids. At the clinic visit, she has high blood pressure. She has active arthritis. And on the blood work, it becomes very clear that she has evidence of kidney inflammation on the urinalysis and increase in protein in the urine. She also has high anti-double-stranded DNA antibody and low complements. So it is clear that there's kidney involvement. What do we do next? Next slide. So we made the point that a kidney biopsy needs to be performed. All patients with proteinuria greater than 0.5 should have a kidney biopsy, and we'll refer them to our nephrology colleagues for kidney biopsy. But in the meantime, to stop that inflammation very quickly, we start glucocorticosteroids intravenously to make sure that while we're waiting for biopsy results, we already have the process, the treatment process started. Next slide. So time is kidney. We need to act quickly, start steroids quickly, biopsy quickly. Next slide. So now we need to figure out, the biopsy came back. This is a class 3 or 4 lupus nephritis that is active. The kidneys are inflamed. There's no scarring. So this is the time to intervene. And I hope I made the point that we recommend that this intervention is the most that we know. And the most that we know is this combination of steroids with mycophenolic acid analog and belimumab or calcineurin inhibitors. And depending on the rest of lupus, we can make those decisions. The patient that we're talking about seems to have arthritis associated. The calcineurin inhibitors were not studied to tell us if they work in patients with arthritis, but belimumab is already approved to treat non-kidney lupus. Accordingly, for this particular patient, we recommend that that triple therapy is steroids, mycophenolic acid analog, and belimumab. Next slide. So everybody continues hydroxychloroquine. Everybody should be on a renin, angiotensin, aldosterone, losartan, or lisinopril. I'm sure some of you have already heard about these medications and already know about that, and I'm happy. We're happy to talk to you some more about it. Next slide. So this is a version of the slide that Dr. Rovin showed you, where those red lines show kidney tissue loss related to one episode of lupus nephritis and then continued nephron kidney loss with ongoing lupus nephritis. So the faster we act, the more aggressive we are in the beginning, the more likely that we'll preserve kidney function. Next slide. And these are some data, and I'm not going to go into the details about from the clinical trials that led to the approval of belimumab, Benlysta for the treatment of lupus nephritis, and how those trials were put together. Next slide. Belimumab inhibits B lymphocyte stimulator, a big a big trophic factor, a big inflammation molecule that's responsible for keeping the antibody producing cells alive and making anti-double-stranded DNA antibody. And these are the data that were looked at the end of 2 years of study that showed that in the light blue bars, belimumab was superior to the standard of care, which is just the combination of CellCept with steroids, or some of the patients in the study were given cyclophosphamide and steroids. Next slide. This is a subgroup analysis that shows variations based on the level of proteinuria. We're not going to get into all these details. Let's go to the next slide. And these are the data from the voclosporin, the calcineurin inhibitor that we already learned from Linda about, that was also approved for the treatment of lupus nephritis. At the time when these guidelines were thought of and organized, the only two medications that were FDA approved for the treatment of lupus nephritis were belimumab and voclosporin. In the meantime, more data is accumulating, so as things change, we might, we will reassess these guidelines. So this is supposed to be a living document. As we learn more and we understand how to better treat lupus nephritis, we'll provide you with updates. Next slide. These are on the left side of the slide, the difference between treatment, the blue bar with voclosporin, steroids, and mycophenolic acid analog, compared to the control arm, which is steroids and mycophenolic acid analog. So both of these trials show very clearly that using the three medications together, steroids, mycophenolic acid, and belimumab, or steroids, mycophenolic acid, and voclosporin, results in better results. And we already know time is nephron, no need to waste any time. Next slide. For class 5, the type of lupus nephritis that's associated with heavier levels of proteinuria, we're proposing that because the calcineurin inhibitors are the ones that perform best in the subgroup of patients in these trials that had class 5, pure class 5, we propose that triple therapy is steroids, CellCept, and calcineurin inhibitor as first line. And as things progress, we might change that. Next slide. So I put together another story of a lupus patient that comes in and shows sort of different scenario a little bit. The blood pressure is just borderline elevated. She has a lot more swelling in the legs. And on the urinalysis, there's no evidence of inflammation. Her double-stranded DNA and her complements are normal. So the story is a little different, and the level of protein in the urine is higher. And that's part of the reason why there is swelling in the legs. So, the way class 5 and class 3 or 4 look clinically and on the testing is different even before we do the biopsy. You might ask, why do we do the biopsy? Because we need to be sure. Next slide. So proteinuria is elevated. The patient needs a kidney biopsy, but also needs to be treated. We don't wait for the result of the biopsy. We start steroids promptly. Next slide. We already saw these slides from Brad Rovin. Actually, they're exactly the same slides because I borrowed them from him. These colorful pictures here show the sort of blandness. There's not a lot of inflammation in these biopsies. The immunofluorescence, where we look for antibodies, shows a lot of antibody deposition, and then the electron microscopy shows those deposits that are subepithelial in that area of the kidney that's part of the filtering membrane, and that's why having those deposits decreases the ability of the kidney to keep the protein in. Next slide. So what do we do for this patient? I think that I already made the point that the patient needs triple therapy with mycophenolic acid, steroids, and calcineurin inhibitor, and that we prefer that to other regimens. Next slide. So the patient is started on pulse steroids. So all lupus nephritis start with pulse steroids so that we decrease inflammation in the kidney quickly and effectively. Started low to moderate doses of steroids, mycophenolic acid, and for this patient, voclosporin. I already told you that voclosporin works better than other types of medications, that belimumab for the treatment of class 5 disease. Next slide. And for class 5, it takes maybe a little longer to achieve that complete renal response, and we shouldn't rush it. But we can add medications to help, like blood pressure medications that help preserve kidney function and lower the risk of damage to the kidney. Next slide. So busy slide saying that if there's no response, we change the medications, we adjust them so that we give the patient the best chance to achieve complete renal response. It is complete renal response that we're trying to get to. And depending on the amount of protein, we may decide to adjust the regimen. For people that have very low proteinuria, we may not use quite the same intensive regimen that we do for people with higher levels of proteinuria. The recommendation that we came up with is that people with kidney disease, lupus nephritis, need 3 to 5 years of treatment after achieving complete renal response, just to make sure we have completely eradicated the inflammation in the kidney. Next slide. And these are some data that substantiate why we made these decisions and how these data influenced these guidelines. Next slide. Next slide. So I already told you that the duration of treatment is 3 to 5 years. So please be patient with your doctor. It takes time. Next slide. And these are recommendations for when there's no response to the treatment. What do we do then? And then what do we do when disease doesn't respond to anything? Next slide. So I think this may be the moment that you are all looking forward to, which is the time to ask questions, and hopefully we can provide some answers. Thank you so much for indulging me and talking about the guidelines and telling you the story about how these came together. Thank you.
Thank you so much, Dr. Askanase. I'm going to turn it over now to Dr. Joy Bowie, who is the Vice President of Research here at the Lupus Foundation of America, who's going to lead us in a panel discussion along with our presenters. And I see, we have quite a few questions coming in already. Everyone's been active, so thank you all so much for joining us and, for answering the questions already. And Dr. Bowie, I'll hand it over to you.
Thank you so much, Sharon, and thank you to all of the panelists who shared so much valuable information on this evening. I also like to thank the participants for staying on for this segment of the webinar, and certainly we'll be recording it, so if you have to hop off, we certainly understand. But we want to make sure that we address at least some of your questions that we've seen in the chat. And so let's get started. The first question is for Dr. Haraki. Can lupus nephritis be effectively managed by rheumatologists, or is it essential to see a nephrologist for specialized care?
It's a great question. So I think as Dr. Eskenays outlined with the guidelines from ACR, there are some guiding principles. And one of the first ones is really advocating for this collaborative care model between rheumatology and nephrology. And this idea that when a patient does have lupus nephritis, that we really should be aiming for that collaborative care model as much as possible. I think we have to consider that that may not be feasible depending on the setting. There are not always conditions where someone is able to have access to a nephrologist or a rheumatologist. It certainly can be difficult to have that coordinated access, but this is hopefully a tool that could be used for patients and providers to advocate for this model.
Awesome. Thank you so much.
Sure.
And this question is not specific for any one of you, but first one, I guess, who can come off mute. Could you speak to the validity of recent claims that GLP-1 medications might have protective effects against lupus nephritis? Additionally, does weight loss significantly reduce the risk of developing chronic kidney disease and lupus?
I'll just mention that I tried to answer this one in the chat, but the GLP-1 agonists are being looked at in chronic kidney disease that is not diabetic in origin. And like some of the other diabetic medications that have been used to mitigate heart disease and diabetic kidney disease, it looks like the GLP-1s may do the same thing. The mechanisms of action are not understood completely yet. Weight loss can have something to do with it. We know that patients who are having obesity are at risk for increasing the sort of blood pressure, if you will, in the glomerular units, the filtering units, and that can lead to damage and progressive decline in kidney function. So I think weight loss may be certainly part of it, but when we do the analyses of the GLP-1s, the benefit to the kidney is not simply due to weight loss. Now, the specific question as to whether they can be used or should be used in patients with lupus nephritis hasn't been addressed yet in any sort of studies, but I will just like to put a plug in that many of us are putting studies together to look at the SGLT2 inhibitors that you've heard about, which also used to be, reserved for diabetics, but now we know can be used in chronic kidney disease, and GLP-1s. So you're going to have to stay tuned, but certainly there is good reason to think that they would work in chronic kidney disease for lupus. They are not and should not be considered as substitutes for any of the immunomodulatory drugs that Anka and Linda have been describing.
Thank you for that, Dr. Rubin. The next question is for Dr. Eskenays. Dr. Eskenays, if my kidneys are failing, should I be inquiring about the utilization of vitamin D to replace any deficiencies or make up for my kidney's inability to convert inactive vitamin D to the active form? The same thing for erythropoietin as well.
So the answer for erythropoietin is simple. Yes. If the erythropoietin is low, then you absolutely should replace it. How to use vitamin D when somebody's kidneys are failing, I don't think it's as clear. And I'm going to ask Brad for help here because I'm not sure that I know how to fully answer this.
Yeah, so it's really interesting. The kidney converts vitamin D that we derive from the sun into, it's called 1,25 dihydroxy vitamin D, which is just the chemical name of it. And that's the active form of vitamin D that we need. And as the kidney fails, that capacity to make the conversion goes down. And so in chronic kidney disease patients, we monitor bone levels. So in other words, we look at calcium and phosphate and parathyroid hormone, and we use vitamin D, but the 125 form to supplement our patients who are deficient. So we can do that, and we often do, and that's usually in the later stages of chronic kidney disease.
Okay, thank you so much for that. This next question is for Dr. Haraki. There are a lot of questions in the Q&A as well as in the chat related to Plaquenil. One of the questions that was asked was related to the optimal dose that should be used of Plaquenil in order to see the effects that were described here. In addition to that, is there a better safety profile as well as a higher level of efficacy for the brand versus the generic versions of this drug?
Yeah, great questions. We talk a lot about hydroxychloroquine, but I feel like we don't have great ways of testing consistently across patients what that sort of magic dose is. And of course, as many people know, it's really only provided as a 200 milligram tablet. So how you manage what the perfect dose is, at least in pediatrics, we do it based on weight. And so we're generally targeting about 5 to 5.5 milligrams per kilogram. And we don't exceed 400 milligrams a day. But I think, as I was mentioning before, we're talking about not just the daily dose, but how much cumulative dose a person has over the course of their life and course of their treatment. And that's where being mindful of that cumulative exposure is really important when we're talking about the side effects with the eye and heart. As far as alternatives, because I did see that, and I think, we do talk about it a lot in lupus, but there are some people who just cannot tolerate it. And I'm not aware of other medications that have been studied to the same extent as hydroxychloroquine and that have been good alternatives that have the same proven benefit. There certainly are other anti-malarial drugs that are used to control other manifestations of lupus, but I don't believe they have the same evidence for overall control. And Dr. Askanase and Dr. Rovin, please correct me if I'm wrong, but that's been our experience, certainly. The question about brand name versus generic. So I think as is the case with so many of the drugs, they're designed to have the same comparable level of active ingredient. And so when we got this question in advance, I just did a quick little search, and there was a paper recently published just a couple of years ago where they tried to compare blood levels of hydroxychloroquine in Plaquenil versus generic hydroxychloroquine, and also side effects. It was a very small study, 27 people in each arm, and they didn't find any differences. But I know certainly among my patients, anecdotally, there are some who really feel that there is a difference when it comes to their tolerability with brand name versus generic. But again, I'm not aware of great data that can back that up. But there are certainly people, I think, anecdotally, who really feel a difference. And so in those instances, we work together to try to get them the version that works well for them.
Okay, awesome. Thank you for that, Dr. Haraki. This next question goes to Dr. Rovin. There have been a lot of anecdotal stories, if you will, and certainly anecdotal evidence related to diet and managing lupus, also lupus nephritis. I know that you're a nephrologist, and oftentimes when the kidneys are beginning to fail or when there is identified chronic kidney disease, there are certain recommendations to preserve the kidney function, but then also alleviate the potential for the development of additional comorbidities. So in general, is there a diet that has been shown to be better in order to, number one, reduce flares, but then number two, preserve kidney function?
So I think that this is a huge question, and we don't really have an answer. I don't believe that we've shown in any way that a specific diet is going to help prevent flares of lupus nephritis. And I know some of the folks on the phone or online have had experience with certain diets, and they've achieved benefit, and that certainly is not unreasonable. And so there's two things. So there's what we know and what may be, but we have to prove it. I was at a very interesting meeting this weekend and I met the author of a book who happens to be a nephrologist, but he talks about using plant-based diets, and one of the viewers talked about that, and as decreasing the overall inflammatory state of us. And we, at least in the Western world, don't eat very well. We have processed foods, processed sugar, a lot of red meat, etc. And that may be somewhat of a pro-inflammatory diet, if you will. Whether or not a plant-based diet can actually work on the inflammation levels of lupus, where things are tremendously elevated, if you will, really remains to be seen. Will it hurt? Absolutely not, as long as the plant-based diet is well maintained, well balanced, and you're getting sufficient overall protein. What we do know for kidney diseases in general, to sort of slow progression and maintain kidney function for as long as possible, is a couple of things. We did a dietary study of reduction in protein intake in patients with chronic kidney disease in the past, and we did show that patients with lower protein intake can actually help preserve kidney function. Now, one of the risks of that is that you can become protein malnourished. And so I talk to my patients a lot about how much protein they take in. I'm a carnivore. I eat way too much protein, but so far my kidneys are good. And, I talk to my patients about what they take and see if we can mitigate that to about 1 gram per kilogram per day of protein or less. Okay, the other thing that's really important for almost everything we're talking about today is to watch your salt intake, because in patients who have kidney disease, sodium can be difficult for the kidney to handle, as you all know. It can contribute to hypertension. It completely detracts from the beneficial effects of a lot of the medications we use to reduce hypertension within the kidney, which helps preserve kidney function. And it also takes away a lot of the blood pressure benefits of many of our medications. So for me, I try to really reinforce the low salt diet. And then, of course, many of these drugs lead to hypercholesterolemia, or our patients who have kidney disease and proteinuria will develop hypercholesterolemia. And so I think dietary counseling in fats and triglycerides is really, really important as well. But there is no magic diet, unfortunately, at this time.
Okay, thank you so much for that response. Go ahead, Dr. Escanes.
Like, highlight a comment that was made in the chat, which is a nutritionist. And I think that as things get more complicated with diets and kidney issues and low salt and low protein and trying to balance all this, a nutritionist can help a lot make sense of this.
Yeah.
I do think that for lupus patients in general, trying to make sense of all this data on diet and kind of figure out how to be healthy and maintain a low inflammation state in general, I think a nutritionist can help.
Awesome. So it looks like we are at time, unfortunately. We will take all of the questions and try to do our best to respond to them and provide an update on all of this information. Again, we want to thank our speakers for their information that they've shared today and certainly the work that they've put in to help shape and form the guidelines that are now going to lead and guide rheumatologists as well as nephrologists in treating this disease. And so now I want to turn it back over to Jaren Crump to give us some final announcements, one of which is to make sure you take the evaluation so that we can continue to offer this type of programming and certainly provide a patient-centric approach to providing this information.
Thank you, Dr. Boyd. Thank you, everyone, for attending. Thank you to our speakers so much for sharing this important information with everyone. Looks like we are at time. You can use this QR code right here to scan to complete an evaluation for the webinar. We greatly appreciate it if you do that. And probably, something very important for everyone is here. Remember to talk to your doctor about what treatments are right for you. We'll be following up with everyone who joined us and people who are signed up to our email list with more details.